Well, welcome everybody to Optometric Education Consultants National Webinar Series Tuesday night edition. Tonight's topic is diabetic case studies, and we're very fortunate to have Dr. Paul Chous as our speaker. He's in private practice, specializing in diabetic eye care and education in Tacoma, Washington. He's an adjunct professor of optometry at Western University of the Health Sciences in Pomona, California. He is the author of Diabetic Eye Disease, Lessons from a Diabetic Eye Doctor, and he is on the review advisor and review boards of Review of Optometry and Optometry Times, and he is an AOA representative to the National Diabetes Education Program. He is one of the top speakers and educators, a top mind in diabetes and diabetic retinopathy, so we're really very happy to have him here. We're very fortunate. So with that, Paul, please take over, and we're looking forward to hearing your presentation. Thanks so much, Paul.
Thank you so much for inviting me, Joe, and Greg, and Vanessa. Thanks for holding my hand to make this possible.
Go right ahead, Paul.
Got it. I wasn't advancing. Thanks. So my practice is pretty much all diabetes, some patients with pre-diabetes. I've had, just from a personal angle, type 1 diabetes for 56 years now. So I know something about it just from a personal experience. But, a lot of patients come to me and they're seeking out advice beyond the eyes. And that's something I know we in optometry do all the time, is we give patients, some advice about things not always directly related to the eyes. Here are my disclosures. And the main thing here is that I've done my best to mitigate relevant financial relationships. So what's diabetes? We all know this, right? But just to review, you consume food. The carbohydrate primarily in the food is converted into glucose within the bloodstream. Blood sugar levels go up. The pancreas releases insulin. Insulin receptors on our cellular membranes are activated. Glucose gets out of the blood into the cell. Blood sugars normalize. So what happens in diabetes type 1 disease, the major defect is there is a loss of endogenous insulin production. Although it's interesting, some studies show even 50 years after diagnosis of type 1 diabetes, some patients still have some residual beta cell function, can actually make a little bit of their own insulin. The next thing that happens is the cellular insulin receptors aren't activated because there's no insulin. Glucose can't get inside the cells, so it builds up in the bloodstream, and there are insulin-independent tissues throughout the body. The retina is one of the prime examples. So glucose at high levels gets inside the retina, and that causes damage. So blood sugar levels never normalize. In type 2 diabetes, the primary deficit is in the cellular response to insulin. It's like a lock on a door that won't open. The key won't fit the lock. So glucose can't get inside cells, blood sugar levels go up. And then as a secondary defect, but it's very common in type 2 diabetes, the pancreas basically runs out of gas. The beta cell volume declines over time, so patients become deficient in insulin. And that's why about a third of all type 2 patients end up on insulin therapy. So in type 2 diabetes, just to recapitulate or restate what I've just stated, you get both cellular loss of insulin sensitivity, and you decrease levels of insulin production over time. Whereas in type 1 diabetes, primarily, there's not enough insulin. It's interesting to know about 45% of patients with type 1 diabetes have some level of insulin resistance. Some people call this type 1.5 diabetes, where you've got insulin resistance laid on top of type 1 diabetes. Just something to be aware of. Here's a cartoon depicting what I just said. And just, this is the cartoonish version. These are actually all the cellular pathways involved. I'm not going to belabor you with these, but just to let you know, there's a lot of potential targets for getting people to be more sensitive to insulin and also to produce more of their own endogenous insulin. So these are really common misunderstandings I hear from patients all the time, and unfortunately from some of my colleagues in optometry and sometimes even in medicine, that use of insulin means somebody suddenly has type 1 diabetes. That's not true. That only overweight and obese people get type 2 diabetes. We know that it's mostly visceral fat that doesn't show up. It's not obvious to the naked eye that somebody maybe has a lot of visceral or abdominal fat, and that's what modulates insulin resistance. And then the other common misunderstanding is that if I'm not taking insulin injections, I've got type 2 diabetes. I've got the good kind of diabetes. And that's not true, because patients with type 2 diabetes have a much elevated risk of cardiovascular and renal complications, as we all know. There's no good kind of diabetes, just like there's no good kind of AMD to have. So here's the first polling question. And if you don't know this, don't worry, because a Johns Hopkins study of community physicians found that about half of the physicians answering this poll didn't get the right answer. So a glycated hemoglobin at or above what level is diagnostic of diabetes? 5.7%, 6%, 6.5%, or 7%? Made it a little tough by bunching the numbers together. So my friends will help me reveal the poll.
The poll is launched. You won't be able to see it the way the system is set up, but the answers are rolling in.
Got it.
5.7, 6.0, 6.5, 7.0. And you're getting a pretty good mix here, as we would expect.
That makes it a better question, right? If everybody gets the right answer, sometimes then there's, you're telling people stuff they already automatically know. But I had a family practice doctor last week that we were talking about diagnosis of diabetes, and he thought that the A1C value was higher than it actually is. And these criteria are established by the International Diabetes Foundation, by the American Diabetes Association, and the clinical endocrinology groups.
All right, so looks like the trend is in. I'm going to display it to the audience. Again, you won't see it, Paul, but the audience will see it now. We've got 21% saying 5.7. We've got 36%. That's the winner at 6.0. We got 26% at 6.25. And we have 7.0 at 13%. So
yeah, nice mix. So the answer is actually 6.5% or above is diagnostic of diabetes by most diabetes organizations. The 5.7 is an interesting one because that's diagnostic for pre-diabetes. And that's a rhetorical question. Is there such an animal as pre-diabetes? There are defined guidelines for what constitutes pre-diabetes. I think there is, but some docs don't really like that whole concept of pre-diabetes. 7% is kind of the level for good, reasonably good diabetes control. 6% doesn't actually play in, although to the people's credit who voted for 6, a good 25 years ago, that was the diagnostic threshold for having pre-diabetes. It's been lowered. So here are the diagnostic criteria. So it's fasting plasma glucose, that's FPG, 126 or above on 2 occasions. You have to fast for a certain amount of time. I believe it's 8 hours. It might be 6 hours. It may say so on the screen. I don't see it because it's blocked. It's a random plasma glucose of 200 or above with symptoms. So the 3 Ps we always hear about in diabetes: polyuria, so you're urinating constantly; polydipsia, you're thirsty all the time; and you're losing weight, typically because glucose can't get into the cells. It's an oral glucose tolerance test of 200 or above at 2 hours. So that's the sugar water test that most pregnant people undergo about the 3rd month of gestation, and they're trying to see if they can provoke elevated blood glucose levels. But in any person, if it's above 200 2 hours after drinking a 75-gram glucose-laden drink, you've got diabetes by definition. And then in 2009, hemoglobin A1C 6.5 and above became one of the diagnostic thresholds for diabetes. And you can see the relevant markers there for pre-diabetes below. They're very well defined. And basically, once you've got pre-diabetes, your risk of getting type 2 diabetes goes up dramatically. Your risk of cardiovascular death is equivalent to a patient that has established type 2 diabetes. Pre-diabetes is not a good diagnosis. So where does glucose cause damage throughout the body? Well, only in places that have blood vessels, nerves, and proteins. And if you think about it, that's everywhere. If you Google or PubMed, diabetes and any known diagnosis, you'll probably find some paper somewhere that establishes a connection between hyperglycemia or diabetes and one of those conditions that you're searching for. So, of course, there's a lot of complications in diabetes. We all know this. It's not just in the eyes. We often think about cardiovascular disease and renal disease. And as it turns out, all these things hang together with diabetic retinopathy. So these are, the one that most of the audience members I speak to live ask me about is gastropathy. So that's a slowed stomach emptying. So patients can eat food. It sits in the stomach for 7 to 8 hours. They take medication to lower their blood sugar. The food sits in the stomach and it's released into the intestine when you're not expecting it to be. So this results in terrible blood glucose control. And there are tests to ascertain if a patient has that condition. So a lot of studies, as I just alluded to, show that diabetic retinopathy is associated with cardiovascular disease, heart attack, stroke, congestive heart failure, and death from one of those. And so as it turns out, a lot of patients are still dying from cardiovascular disease. And this is my rhetorical point, I guess, which is preventing vision loss from diabetes is not quite as effective if your patient dies prematurely from a cardiovascular event. And about 2 out of every 3 patients on metformin alone, the most widely prescribed diabetes medication in the world, remain at high or extremely high cardiovascular risk. I gave a talk in Oslo, Norway last February, not the time probably to go to Oslo, but I spoke with a diabetologist from the University of Oslo, and he had published this interesting paper. And basically the bottom line was that we have drugs now that provide cardiorenal protection. They dramatically lower the risk of cardiovascular events and death and renal failure. And most patients that are eligible for these agents are not being prescribed them. And 2 very simple agents, classes, glucagon-like peptide agonists. Those are drugs like Victoza, Wegovy, Ozempic, right? The ones that help with weight loss, but also the sodium glucose transporter reuptake inhibitors. These are drugs that you see on TV every day, Jardiance, Farxiga. These drugs all have been shown to lower cardiovascular event and death risk, as well as renal failure risk. And we're probably not using enough of these drugs. And the reason I brought this up is the endocrinologist, he was a cardiologist, actually, I spoke with in Oslo, said, I want everybody who's an eye care provider. This is about 800 optometrists in Norway. He said, I want all of you to talk to your patients about the benefits of these drugs. Talk to their primary care physician. Ask the patient to advocate for themselves and get placed on these drugs. They're more expensive, but they save lives and they reduce overall cost to the healthcare system. So we all know this. Diabetes prevalence is going up. About 1.5 million people a year were getting diabetes in 2018. It's a little less than that now. We're doing a little better. In addition to 37 plus million Americans that have diabetes, there's another about 100 million Americans that have prediabetes. And we know if enough time goes by and those patients live, they're likely going to develop type 2 diabetes as time goes by. Well, one study in 2012 said that NHANES patients, more than 50% had either prediabetes or diabetes. So it's kind of become the new norm in adults in the United States. And of course, the obvious predicate here is that you're not going to lose your eyesight to diabetic retinopathy if you don't develop diabetes in the first place. So CDC said that diabetes was an epidemic in 1994. So here we are 30 years later. Are we stemming the tide? No, prevalence is going up every single year. The incidence is down a little bit. There was a big increase in type 2 diabetes and type 1 diabetes during COVID. The SARS-CoV-2 virus attacks the pancreas, as it turns out, knocks out pancreatic beta cells that make insulin. So in 2012, it was about 1 in, I got to move my own picture of my face out of the way. It was 1 in 10 patients. By 2050, it's expected to be between 1 in 3 and 1 in 5 people in the United States with diabetes. Right now, it's about 1 in 9. So the facts about diabetic retinopathy, there's a lot of references to old literature that says there's about 4 million patients. It's doubled from that per the American Society of Retina Specialists. In 2020, they estimated 8 million Americans with some degree of diabetic retinopathy. And really what we want to worry about is more advanced stages that rob people of their vision. CDC says about 1 in 3 people have DR, so that would be 12 million people. It doesn't really matter. It's a lot of people. The numbers are going to go up by 2050, probably around 20 million people in the US with diabetic retinopathy, and it remains the leading cause of new onset blindness in working age adults in the US. Not true anymore in the United Kingdom, where I'm going next month to speak about diabetes. They have been able to cut away the numbers of people going blind from diabetes using telescreening techniques in every PCP's office, in pharmacies and the like, to try to get people evaluated and get them referred in earlier. That's not the American model. If we want to reduce blindness from diabetes, in my opinion, that's what we need to do. So a lot of people get diabetic macular edema. It remains the leading cause of vision loss, not blindness, but vision loss in people with diabetes. About half of patients with DR, diabetic retinopathy, ultimately will develop at some point diabetic macular edema. It's more common in Black and Hispanic Americans. And as I said, it's the leading cause of vision loss in people with diabetes. So what are some of the risk factors for diabetic retinopathy and diabetic macular edema? We've all seen these, right? We're all familiar with them. So more rhetorically, I'll ask, which ones are modifiable? Well, really, they're all modifiable except disease subtype. There's things that can be done about all of these. Disease duration, some people say, well, that can't be really modified. It can by preventing the development of type 2 diabetes in particular. And now we have a drug called Tzield that actually delays the onset of type 1 diabetes by about 2 years. So I think this is one of the more important studies done in public health in the United States of the last 50 years. The diabetes prevention program showed you could take high-risk patients with prediabetes or who had gestational diabetes and lower their risk of developing type 2 diabetes significantly by having them walk 30 minutes a day, 5 days a week. This strategy was twice as effective as giving these patients metformin. Metformin lowered the risk of getting diabetes, but it was only about half as effective as walking was. And the comparator group was people with usual care, which typically for prediabetes is eat better, get more exercise, no specific program to prevent the onset of the disease. Metformin worked best, by the way, in patients that were younger and people that had a high BMI. So it's extreme obesity if you're 35 or above. So this is just a graph of the diabetes prevention program showing almost a 60% reduction at 4 years. The benefit wore off a little bit to 38% by 10 years. We have data now going out 28 years where the people who continued to walk, and even those who stopped walking, have lower rates of conversion from prediabetes to overt type 2 diabetes. This is a really important point. So you don't want to get diabetes to avoid diabetic retinopathy. And I think that we're not talking about this enough yet. We know now, based on a bunch of studies, that severe hypoglycemia leads to worsening diabetic retinopathy. In animal models, it kills photoreceptors. In this big study done in Western Australia, the biggest predictor of losing vision to diabetes was not high A1C or duration of diabetes or even cigarette smoking. It was being hospitalized for severe hypoglycemia, low blood sugar. It's the opposite end of the scale from hyperglycemia, right? We got to tell our patients, especially when they develop early non-proliferative retinopathy, not to experience severely low blood sugar levels. And that's defined as a blood glucose of 70 or less for a mere 15 minutes. So this is a study done in human cultured retina. Episodic or chronic hyperglycemia ramped up something called glucose transporter 1, and another very important protein that's linked to VEGF, vascular endothelial growth factor, known as hypoxia-inducible factor 1A. So when human retina was exposed to hypoglycemia, low blood sugar levels in a petri dish at least, the levels of hypoxia-inducible factor went up 100-fold. So this is the current model from the retinal biologists. Chronic hyperglycemia leads to early diabetic retinopathy. You get hypoxia. But if you take that hypoxic retina and subject it to more stress by having a hypoglycemic environment, that is what promotes severe diabetic retinopathy and vision loss. Something for us all to be aware of. So the bottom message here, the bottom line message is patients with early diabetic retinopathy really need to be advised to avoid hypoglycemia as much as possible. So that's easy to say. How do you do it? Well, one strategy is to have a low glycemic index, Mediterranean type diet. Every study that's been done shows better blood sugar control with less episodes of hypoglycemia on a variety of Mediterranean type diets. The other thing that really helps, as Greg already showed us, he's wearing a continuous glucose monitor and it's under my jacket now. These devices alarm you when your blood sugar levels are dropping. Before you get to a hypoglycemic threshold, it will alert you to that fact so you can take action to avoid hypoglycemia. And again, remember in these studies, and it was subsequently shown in an animal model as well, 15 minutes of hypoglycemia was enough to cause a 100-fold increase in hypoxia-inducible factor 1A. And that led to about a 50-fold increase in VEGF, right? That's what we're treating with these injections into the eye for DME and DR. So what's some good advice for our patients with diabetes to try to minimize getting diabetes, improve blood glucose control, hopefully reduce the likelihood of developing diabetic retinopathy? Well, when you go to the supermarket, this is my typical advice. Try to spend your time on the aisles on the outside, right? Where the vegetables and the produce is. Avoid processed high sugar foods. Stay away from the middle aisles, basically. Limit fast food because there's a lot of hidden sugar in fast food. Even a little package of ketchup from McDonald's has 3 to 5 grams of refined sugar added to that. So that's another source of sugar. Get outside and exercise. Try to find something you like doing. Find a partner. It doesn't have to be vigorous exercise to lower the risk of type 2 diabetes. It's better if you vigorously exercise, but even the 90-year-olds in the diabetes prevention program, and they had a cohort of about 80 people over age 90, the ones that walked significantly reduced their risk of developing type 2 diabetes over the next several years. So I'm going to close down this one little bar that's blocking me out. So we got a polling question again. So this question is: significantly improving glycemic control is most likely to prevent progression of diabetic retinopathy in which stage of the disease? Is it when somebody has no retinopathy or mild non-proliferative diabetic retinopathy, moderately severe non-proliferative retinopathy, severe NPDR, or proliferative retinopathy? So when is good glycemic control, improving it, most beneficial? I think most eye care providers, because I see this all the time from retina specialists, told the patient to get improved glycemic control. Well, when is it most beneficial? That's the question.
The attendees, they're starting to roll in with the responses. Joe, I'm not sure if there's anything in the chat box. I did see that our attendee, Paul, just so you know, you have someone all the way in from Central Europe time zone, which means right now it's 2:32 a.m.
You are a better man, woman than I am for sure.
They are rolling in the answers. Joe, anything in the chat box that I don't want
There
to
is
click
not
over?
just a couple hellos and good messages.
So we're all telling our patients get better blood sugar control when we see DR, because that's kind of what the mantra has been for the last 50 years, since the early studies in both type 1 and type 2 diabetes showed improving blood sugar control lowered the incidence and the progression of diabetic retinopathy. So this question is a little kind of a more subtle question. When is it more beneficial? When does the patient actually experience a benefit? At what level of disease?
And so I just displayed the answers, and we have 83% saying no or mild non-proliferative. Then it drops to 13% for moderately severe, then severe is 4%, and no one took the bait for proliferative diabetic retinopathy.
Yeah, so great audience. I mean, that's wonderful. So this comes from the Panorama trial that took people with moderately severe or severe non-proliferative retinopathy, and they used aflibercept to see could they prevent vision-threatening complications or center-involved diabetic macular edema. We'll talk more about that in a moment. And both of these trials, Panorama, and then the federal government, the National Eye Institute, did Protocol W, Diabetic Retinopathy Clinical Research Network. Both of those studies said no. In fact, people with better hemoglobin A1C when they were enrolled in the trial did worse. They were more likely, that's what the solid blue line shows, to develop center-involved DME or a vision-threatening complication defined as proliferative retinopathy or anterior segment neovascularization, so iris rubeosus and the like, right? So improving glycemic control gives you the most benefit when you have mild retinopathy or no retinopathy. That's the key point here. So an eye to the future, that's kind of one of the subtitles of my talk. You know, AI can detect diabetic retinopathy just as well as retina specialists now. It's getting better. Is it going to replace us? I don't think it's going to. But I think we do need to establish our value beyond just detecting diabetic retinopathy. We need to do more than detect. We need to try to prevent it, stage it accurately so that intervention can be applied at the correct moment, and then hopefully predict an individual's patient's risk of progressing on to a form of the disease that threatens their vision. And we can do this with our own clinical acumen combined with technology. So that's the point I'm going to try to make as I move through these slides. So now we finally get to cases. I'm a few minutes into it, but let's roll with some cases. So this is a young man I saw for the first time. He's had type 1 diabetes for 12 years. He just graduated from college. And he says, yeah, my blood sugar control is just fine. You know, but when I asked him, and this is the most important question to ask your patients, not what is your A1C now? That's an irrelevant question for the most part. What you want to ask is, what's your A1C been since you got diagnosed? Did you start off at 15 for a number of years, and then it took you 5-10 years to get it under control? Because that confers way increased risk for the rest of that patient's life. And that's what this patient told me is, yeah, I had an A1C as high as 13 for a number of years. I finally got it under control. I saw an ophthalmologist about 100 miles from my practice 14 months earlier, and he was told that he had some early changes, but he could be seen every other year if he kept his A1C at a good number. And the patient came in complaining of reduced vision in his right eye for a few days. He's 2,400. I can't improve it. So what's the most likely, culprit here? It's what I think you're all predicting. Thought it was kind of a cool, boat or yacht-shaped hemorrhage, pre-retinal hemorrhage. So this patient clearly has proliferative diabetic retinopathy. So he got referred to retina specialty. He ended up getting anti-VEGF injections. Eventually, he actually ended up getting some limited PRP laser, which seems to be what retina specialists are doing, is kind of combining therapies now for diabetic retinopathy, because you don't lose as much night vision or visual field if you do a little less laser. But if patients don't come back for an anti-VEGF therapy, they're less likely to become blind. And my argument here is this patient is a really strong argument for first of all, not seeing an ophthalmologist who doesn't know what he's talking about, but also for less frequent eye examination. Throughout Europe, there's been a push to see patients less frequently, especially in countries that have nationalized healthcare. So I've done a lot of lecturing in Iceland and now in Norway. And so they are all recommending kind of intervals that are often longer than a year based on the patient's level of retinopathy and their current glycohemoglobin, glycated hemoglobin, hemoglobin A1C, right? So as I've just argued to you, the current A1C is mostly irrelevant. It's the long-term variability in hemoglobin A1C that's far more important. I had another bullet point here I'll try to bring up. There it is. So the thing to remember here is good A1C doesn't protect you from vision-threatening complications. Once you've got more than moderate, what's now called diabetic retinopathy surveillance scale, severity scale, not surveillance scale. So it's diabetic retinopathy severity scale of level 43. Above that level, good A1C doesn't appear to be protective against worsening retinopathy. That's the key point. And this just shows this whole notion of metabolic memory. This is from the DCCT edict trials, which were all type 1 patients done in the 80s. But the same thing has been shown in massive clinical trials of people with type 2 diabetes as well. People that have good control early on, despite the fact their blood sugar goes down the toilet as years go by, they remain for the rest of their lives at lower risk for developing diabetic retinopathy and for developing severe retinopathy, whereas patients that have bad control early on, it's as if the retina remembers how shabbily you treated it for the rest of that patient's life. After about 5 to 8 years, the risk of severe retinopathy remains elevated. It's probably total glucose exposure is what's going on here. So that's called the legacy effect. So let's talk about some of the technologies more sophisticated than just a fundus color fundus photograph. So using OCT to better see DME. So here's a patient that I saw. She's 52 years old. It's actually a male, forgive me if he's 52 years old. He's had type 2 diabetes not very long, 5 years. So when I see a duration of diabetes in type 2, I always add 5 years to it, because that's what the data shows, is by the time the typical American patient gets diagnosed with type 2 diabetes, they've already had diabetes for a minimum of 6 years. And that's based on the prevalence of diabetic retinopathy at diagnosis of type 2 diabetes. So this patient's probably had diabetes in reality 10 years. His blood pressure is too high. Says his vision's been fuzzy. I forget to take my meds. This is a question I'm asking every patient now, especially if they're with their spouse in the room. Do you stop breathing at night? Have you been told you stop breathing? Do you have to be woken from your deep sleep because your spouse is worried that, you passed away because you've stopped breathing? And the wife, he said, no, I'm fine. But the wife, who was in the exam room, said, yeah, you do. You stop breathing all the time. I've told you that. Men are just notoriously bad patients. His A1C wasn't bad recently. He's got some early cataract, but clearly that's not what explains his vision loss. He's on the usual type 2 diabetes meds, isn't he? Metformin, losartan. He's on hydrochlorothiazide. I'm not a fan of that drug. I'll tell you why later. He's on a statin and he's on a baby aspirin. If they put all these meds, by the way, in a single poly pill, that would treat probably about 80% of people with type 2 diabetes. The only one I don't like is the hydrochlorothiazide. And I'll just tell you now, it worsens insulin resistance at high dose, above 50 milligrams. All right. So what test has to be done? So these are the color fundus photographs, and I think everybody would agree you need to do an OCT on this patient, right? To look at the level of retinal fluid accumulation, right? So, and just highlighting here, this was from my Norway talk that I gave, because they were not as familiar with the various manifestations of diabetic retinopathy. So just wanted to point out to them, there's a cotton wool spot, there's hard exudate and the like, and you could see, microaneurysm formation and dot and blot hemorrhages everywhere. So this patient had, center-involved diabetic macular edema. His blood pressure, elevated. We can see that the central subfield thickness is high, right? So generally anything above 310, it's diabetic macular edema unless the patient has an epiretinal membrane. So this patient for sure has CI, center-involved diabetic macular edema. Left eye worse than the right is what the plot shows there. So there's the diagnosis. I already gave that away. Probably has severe non-proliferative retinopathy. I didn't spend a lot of time on the image, but the patient had some at least modest vein beating in 2 quadrants. So whenever I see vein beating anywhere, I'm always thinking about ischemia. It seems to be a really predictive factor for worsening of diabetic retinopathy. Probably has obstructive sleep apnea, and there's a bunch of studies now that show if you have untreated apnea, you are more likely to get DR and DME and have them get worse over time. So this patient got referred out to a retina specialist. I was right. The wife was right. The patient has severe obstructive sleep apnea, 42 apneic events per hour. So anything above 30 is considered severe apnea. Under 5 is normal. 5 to 12 events per hour is mild apnea. 12 to 30 is moderate, above 30 is severe apnea. So this patient was put on Ozurdex and ended up getting glaucoma, got anti-VEGF injections, was put on CPAP as well. So what's the significance of center-involved diabetic macular edema? And what does it mean? Essentially, it means, and this is based on OCT technology, we didn't have this concept. We had clinically significant macular edema, which has largely become an anachronism given, OCT. So if the center 1 millimeter of the macula is involved, that central 1 millimeter, if it contains fluid, that's center-involved diabetic macular edema. That's the bottom line here. So that brings us, I think, to the next polling question, which is eyes that have center-involved DME are how many times more likely to experience moderate vision loss, which is defined, and it's misspelled there, my apologies, a doubling of the visual angle, which means going from 20/50 to 2100, compared to an eye that has non-center involved DME. So again, we're comparing two patients, two subtypes of patients that have diabetic macular edema. One's got it in the central 1 millimeter. One has diabetic macular edema outside of the central 1 millimeter. So the question is, how much higher is the risk for this person to have moderate vision loss, a doubling of their visual angle? Any questions, please shoot them out, and Greg and Joe will forward them to me, and I can answer anything if anything doesn't make sense.
No, we're all good. You're all caught up.
Polling questions, they're rolling in here. Responses. Looks like the trend is set here. So give it another minute or another 5 seconds here for people to respond.
It's kind of a nitpicky question, isn't it? Because the reality, they're all higher risk, right? So that's the thing to remember. If it involves the center, the patient has a higher risk for losing vision. So does it really matter if it's 3.8 times or 4.6 times? Probably not.
Well, we've got a little 13% saying 2 times. We got the majority at 40% saying 5 times. We've got 13% saying 7 times, and 10 times is 33. So 5 and 10 are your leaders, with 5 being the leader, and then tied at 2 and 7.
The risk is higher. That's the bottom line here. As it turns out, it's actually 10-fold higher. That's what data from ETDRS and subsequent macular edema trials have shown. So there it is. Eyes with CI, center-involved DME, 10-fold greater risk of moderate vision loss. Okay, so beat that one up. So this is a rhetorical question. I didn't do it as a polling question, but I'm asking the audience, and you can, send in your response if you want to on the, what did I say? Should we perform? I thought I said preform. So should we do OCT on everybody with diabetes that comes into our office? And I've heard arguments both ways, and I've been on both sides of this question, no way or yes way. So my current feeling is it should be done on every patient as a baseline so that you have something to compare with in the future. In my office, it's me and a front desk person that makes my appointments and collects copays. The patient's dilated, they're sitting with me. I've got time while they're dilating. I'm talking to them, I'm educating them. So I'm doing OCT, virtually on every single patient. Now, I'm not billing it if they don't have diabetic macular edema, but I like to have the data. Other colleagues of mine, really smart guys in retina, maybe doctors, Sauka and Caldwell would say, well, that's baloney. Why are you wasting your time if your clinical exam showed no diabetic macular edema? And I'll make a case for why maybe that ought to be done. And this is a patient of mine I've been seeing for 20 years now, type 1 diabetes. And she came in with missing 1 letter on the 20/20 line. She's had some mild NPDR. She's pregnant at this time. She had to go through in vitro fertilization, and she'd lost her prior pregnancies, and she was really worried about the pregnancy making her diabetic retinopathy get worse. Type 1 patient. And we can see on the OCT, she's got a little bit of fluid within her macula. I forget which eye this is, but what's interesting is that patients that have subclinical, which means you don't see it by clinical exam, subclinical DME that's only picked up by OCT, these patients are about 3 times more likely to develop center-involved DME that affects their visual acuity. So I think it's an argument for looking for, undetected levels of DME in patients with diabetes. The other thing you'll notice about the OCT, by the way, look how thin the retina is. This is something I see all the time in people with long-term diabetes, especially type 1. It's called retinal diabetic neuropathy. The inner layers of the retina die, just like you get neuropathy in your feet, hands, autonomic nervous system. It happens in the retina. The inner retina is a lot of neural elements. They die, they thin out, something you see. And the reason it's important, inner retinal thinning has actually been shown to increase the risk of cardiovascular mortality.
Hey, Paul, can you maybe point out, since
Yeah.
you're kind of focusing on that 1 millimeter?
Yeah.
To me, this scan here is probably about 5 millimeters wide. Maybe show that 1 millimeter danger zone of that center involved. Kind of maybe point that out on the screen.
Yeah. So are you seeing the yellow arrow that popped in, or are you seeing it?
I do.
Greg, on your
Yep.
screen?
Yep.
Yeah. So there's a little pocket of fluid. There's another one adjacent to it. You can see some little, what do we call it, Joe? You can tell me better. Is it hyperreflective foci? Those are probably some hard exudates, things that have leaked out of the vasculature. So,
Most likely that's what it is.
Yeah.
Yeah.
So and that's actually been shown to be a risk factor for getting worse DMEs if you have these hyperreflective foci. And I guess I'm belaboring the point, but I think it's a good idea to do OCT on patients with diabetes, at least as a baseline, and then periodically thereafter. Certainly if they develop DR and you want to assess for the presence of the leading cause of vision loss, which is DME. This patient, though, and I'm wrong. I said they were 2015 here. Thought they had missed the letter on the eye chart. It may have been at follow-up. They started, this particular young lady lost, a letter or two, maybe a line plus on the eye chart because of this CIDME. And when the vision's down at all, are these patients typically treated now? My experience is no, they're typically watched by retina. So I can watch patients, so can you. So until the patient really requires treatment, a lot of times I'm hanging on to patients with even center-involved diabetic macular edema as long as they have good visual acuity, because a big study was done looking at this exact question, Protocol V. And it said basically observation was as effective as treating the people with laser or with anti-VEGF injections. Here's another patient. So this is a type 2 patient, first seen in 2018, 62 years old, A1C is 8%, obvious diabetic macular edema, does have apnea, uses CPAP, is on Lantus. And this is a new finding in type 2 diabetes. People on insulin have the highest risk actually for developing not DME, but proliferative diabetic retinopathy. So patients on insulin, and it may be because they're more hypoglycemic, it may be that insulin is a surrogate for having terribly high blood sugar, not necessarily low. It could be both of those things. But really look carefully at your patients on insulin therapy with type 2 diabetes. And there is the OCT, the color map, which I know we're told to disregard, but it's abnormal. So this patient got referred to retina specialty in 2019, got treated. They started with, shouldn't have used the brand names, but started with bevacizumab, went to ranibizumab, and then finally to aflibercept. Vision 2100. So didn't really get a good response to the anti-VEGF therapy. And it's somewhere around 50% of patients are said to have suboptimal response to anti-VEGF therapy for diabetic macular edema. So we need other treatments. A1C is fine, and that's good. There's just a picture of the Ozurdex implant there in the middle that's next to a grain of rice. So the rice is the larger object there. So you can see how small this dexamethasone implant is. And it works like gangbusters. The problem is in this patient, she got steroid-induced glaucoma. Her central subfield thickness on the OCT got better. Her vision improved, but her IOP jumped up to 47. And you can see there just that her OCT is looking better. So on follow-up, exam, this patient's getting basically every 6 weeks an aflibercept injection. A1C is fine. She's using her CPAP. So I'm asking patients now, can you take a picture of your CPAP device? Because it'll actually say, how many hours on average a night are you wearing the CPAP? It's a way to try to ascertain compliance, right? So the patient's vision, is now 20/80, and the macular fluid is back up again, and her IOP remains high, even on cosopt, timolol, dorzolamide, generic, her IOP remains 24. So some patients get, long-term glaucoma after, steroid therapy that is just unrelenting, it appears. That happened to my patient. So the key point here is that not everyone responds well to anti-VEGF therapy. The other thing is, steroids work like gangbusters, but you can have side effects, obviously. There's a new steroid eye drop that I don't think has come to market yet. It was developed by a friend of mine who's a retina specialist at the University of Reykjavik in Iceland. It's a topical dexamethasone prodrug. So those of you who are old like I am, remember Propine, right? A prodrug for epinephrine to treat glaucoma. So he developed a prodrug for dexamethasone that doesn't appear to raise intraocular pressure and actually did result in about a line plus worth of visual acuity gain in people that have diabetic macular edema that didn't respond all that well to anti-VEGF injections. So the bottom line here is there's a need for complementary therapies for diabetic macular edema in some, maybe, a lot of our patients actually. So what are some current possibilities? Well, faricimab, right? Because it's got two different proteins that are blocked, VEGF, but also Ang2. And so patients do seem to have improved diabetic macular edema with this drug compared to, a single action anti-VEGF therapy in some cases. Integrin inhibitors, that's another way to block the pathways that lead to DME. I was involved as a study safety person on the safety committee for a company that tried an eye drop using an integrin inhibitor, and it worked like gangbusters on mice with diabetes, but it totally failed in the clinical trial. So there, 3 years of my life and $25 million of the company's money up in flames. It just didn't work, unfortunately. There's several oral therapies that are in the pipeline. Some of these come out of Harvard University. The plasma kallikrein inhibitor is being developed by a group at the Joslin Diabetes Center. So there may be some oral therapies that give us some benefit. And then photobiomodulation, right? Just like it's being used in ocular surface disease, lid disease. In animal models, at least, photobiomodulation causes an improvement in diabetic macular edema. The studies in humans haven't been all that promising thus far, but may need a different protocol for using it. In the talk I gave, with Joe previously, a couple months ago now, he talked about using a port delivery system with ranibizumab, and that may be another way to address diabetic macular edema that doesn't respond to injections every month or two, because you're getting kind of a chronic level of the drug released into the eye, and that might in fact result in better visual outcomes. So now I'm moving from OCT to ultra wide field imaging. So it's been shown that ultra wide field imaging actually doesn't predict worsening of diabetic retinopathy. Harvard published a study several years ago that suggested that. Federal government did another study that looked at the same question and found that, in fact, more retinopathy in the periphery didn't predict people getting worse. But what it did do is allowed patients to be categorized more correctly for the severity of their diabetic retinopathy. So there's the statistic: 12% of eyes, when you look at wide field imaging, ultra wide field imaging, had a higher level of diabetic retinopathy graded by the retina specialist once they looked at the retinal periphery. And this is important because severity of retinopathy is one of the definite key predictors of people getting worse over time. You want to know if a patient has moderate disease or moderately severe disease, because the risk from one to the other goes up about 5-fold for suffering vision loss. So here's another patient MP, 58-year-old female, type 2 diabetes. Hadn't seen this patient before. Like most of our patients, at least many of my patients, A1C, it's good, right? Or it's 120. Patients don't really understand what it is. We probably should lose A1C. In fact, there's a push within endocrinology to stop using hemoglobin A1C as the gold standard for diabetes management. This patient sees well, and I'll show you her optic disc and center involved. Here's her wide field image. So here's just a disc-centered image. Jay Haney, who's a colleague down the street from me, who's in a retina specialty practice, actually took these images. It was my patient that I referred to him. So I asked the question here, the retinopathy doesn't look that bad in this disc-centered photo, right? But if we extend beyond the disc and we look farther out into the periphery, there's a lot of action going on there in the mid-peripheral retina, right? A lot of blood hemorrhaging. This retinopathy is worse than maybe you would have thought otherwise. So this patient was graded by Jay Haney as having severe NPDR. And I saw some vein beating, and I think I said that it was moderate, but when you look at the periphery, it's clear that it's way worse than you think by just looking at the posterior pole. So let's talk about OCTA. So I'm not an expert in this. I borrowed some cases from Julie Rodman, who's a friend at Nova, teaches there and works in the macula clinic. So I want to thank her for these images. So here's a 45-year-old African-American female, doesn't specify the type of diabetes, but says, my A1C is good. My blood sugar control is excellent. It's 7%. I'm really proud of myself. So that's great. So Julie's way of looking at patients is the following, and I think it's a totally rational rubric. What's the history? This patient's had type 2 diabetes for 10 years. A1C is good now, but again, that's the least important question, in my view, you can ask a patient. Ask them, what's the history of your A1C over time? Fasting blood sugar is good. She's on metformin, no other comorbidities. Ocular exam, totally normal. Ancillary testing, OCTA is what Julie did. And so she noticed a few microaneurysms on clinical exam. And most people would say, okay, you could probably come in 12 months, be reevaluated. And I'm just kind of zooming in here on the retinal findings. You see a few microaneurysms, maybe they're little, dot hemorrhages superior to the fovea there. So Julie's a fan, and I'm becoming increasingly so, of OCTA, so optical coherence tomography angiography. So it's like doing an autopsy, right? Layer by layer of the human eye, right? You're getting an histological look at the retina, and you can look at the retina at various levels. And what's been shown is that in the deep capillary plexus, in the internal retina, but deeper down, changes there seem to be predictive of people whose retinopathy is going to get worse over time. So here's a normal superficial capillary plexus, SCP, and a normal deep capillary plexus. And then here's her patient. You can see there's a lot of microaneurysm formation there that you don't really see on the clinical exam or the color fundus photography. So Dr. Rodman asked this rhetorical question: might you want to see this patient back more frequently? And I would say, personally, no, because I'm not convinced that this is that predictive, but there are other tests that I think are more predictive. So Joe can disagree with me. Maybe Greg will disagree with me on that, but I'm not going to personally change my management. I'm probably going to see that patient back. They've got good blood glucose control now, not a lot of hypoglycemia. So I'm probably fine seeing them in a year. But I do another test that I'll talk about momentarily. So here's another,
Paul.
and this makes
Paul,
absolute sense.
Yeah, I'll just make a quick comment. I'll just
Please.
do a quick comment because I've been teaching OCTA. I've had OCTA in the practice now for probably a decade. And you're right. I don't think it really predicts that more retinopathy is coming, but I think it's useful in finding the retinopathy that is existing and helping that patient understand that there's damage, because there's times whenever, we'll do a fundus photo, you'll do a dilated exam, and you'll say that there's no diabetic retinopathy when there actually is diabetic retinopathy, because, diabetes is a capillary disease, right? And why are we looking at structure when we can look at the capillary? So, you can pick it up before it. I agree. I don't think it's a predictor. It's just showing you that you have diabetes maybe before some of the conventional tests that we have.
And I agree 100%. What is it? Adaptive optics. You can show diabetic retinopathy lesions within 6 months of the diagnosis of type 1 diabetes.
Yeah.
So it just depends on how much technology, how much time are you going to spend on it. I think the payoff for OCTA, except in the circumstance you outlined. So if you want to tell somebody they have no DR, you're probably better off doing an OCTA to make sure you know what you're talking about, that you're correct. But it doesn't change my management whatsoever. Most retina specialists, except in this case that I'm going to show now, have told me they think OCTA is a waste of time. That doesn't mean they're right, of course. Retina specialists are wrong all the time. Many of them don't know the first flipping thing about managing diabetes. That's just the reality. And that's from personal experience for decades. So this patient comes in, says to Dr. Rodman, my vision hasn't been good. It's getting worse. Could it be my diabetes? Visual acuity best corrected 20/40. So again, type 2 diabetes for 20 years. A1C is bad in this case now, probably was bad before as well. Fasting blood sugar high. Patient has high blood pressure and hypercholesterolemia, is on medications for those. There's no neovascularization of the iris or elevated intraocular pressure. So the ancillary testing again, first of all, I'll show you the color fundus photography. So, Julie says here, let's grade the retinopathy. So, there is some dot blood hemorrhages at the 10 o'clock position. Maybe that's IRMA. I don't know. I have trouble, and retina specialists tell me they have trouble evaluating IRMA without an FA, a fluorescein angiogram. So I don't know. It could be. It's not mild though, right? This patient also has hemorrhages and cotton wool spots as well in the image. So probably a little more than mild non-proliferative disease. So Julie did an OCT. Is there any macular edema? No. This patient's foveal contour is totally normal, no fluid. Why is the vision down? It's down because of what I call the ugly stepsister of diabetic retinopathy, which is foveal ischemia. So studies say somewhere between 8 and 20% of patients with non-proliferative retinopathy have some degree of foveal ischemia. And the best test for picking it up is actually OCTA. This is where OCTA actually trumps the fluorescein angiography. So here's, Julie's images of this patient. You can see the foveal avascular zone is enlarged. There's a lot of capillary dropout. There's no treatment for this, unfortunately, yet, although I reviewed a paper recently that was calling for more research into therapies for foveal ischemia. So, it's all good and well to talk about therapy. We know anti-VEGF does not appear to work. So you're going to need to regrow vessels, right? And so that remains a challenge, just like it does in any form of ischemia. So it's the ugly stepsister. And Julie put in this nice summary slide that just shows, what is the accepted protocol for treating patients with various levels of diabetic retinopathy and diabetic macular edema. And there is no, recommended treatment for macular ischemia, other than maybe get better blood sugar control, which I would argue is mostly noise in the wind. Doesn't really make a difference. So here's another patient referred by her primary care doc to Dr. Rodman. And look at those hemorrhages. Are they intraretinal hemorrhages or are they on top of the retina? Is it hard to tell? I think the one on the right eye, so the left image there, it looks like pre-retinal hemorrhage, right? So whenever in a patient with diabetes, and I don't like the word diabetic, by the way, just because I don't call my patients macular degenerates or epileptic, you know. So I try not to identify people as their diagnosis, but that I'll get off my high horse. So it's a pre-retinal hemorrhage. And so you got to find out what's the cause, just like you would in a patient with drusen. Why does the patient have a pre-retinal hemorrhage? So again, type 2 diabetes, don't know how long they've had it, high blood pressure. This patient had a left-sided hemiparesis due to a cerebrovascular accident, and visual acuity is okay, normal IOP. Julie did an OCTA, and do you think it showed something abnormal? Yeah, it sure did. Where's the neovascularization? So on the color fundus photography here, it's really hard to appreciate it. Once you know where it is, it might be easier. So let's see where it is. So look at those zones that are jet black, right? That's non-perfused retina. And you can see fronds of neovascularization growing there right at the edge of the non-perfused retina, actually in both eyes. So this patient has proliferative diabetic retinopathy, requires a referral to hopefully a retina specialist or a general ophthalmologist that has a lot of experience in retina. So you might be able to pick up on things with OCTA you might not see otherwise. I think it's a great technology. I actually have it in my office. I just don't use it all the time unless I'm, want to write up an interesting case report or involved in a clinical trial. So there are the areas on the color fundus photography. And now that you kind of know where the neovascular fronds are, you might be able to see them a little better. I'm taking a quick look just to see where I'm at. Okay, 6:05. All right, I'm moving along okay. I'm past the halfway point. I hope I'm not killing anyone in the audience. Honest to God, if you got questions, if you think I'm off my rocker, send in a comment. I'm happy to entertain any and all comers to my talk. So, what Julie did, of course, was refer this patient to a retina specialist. So let's talk about a couple of non-eye cases that are linked to eye disease worth considering. So this is stuff you're going to see all the time in your practice. And that's why I want to talk to you about them, because you can help your patients, you can save their lives actually in some cases. So here's a patient, 62 years old, has had diabetes a long time. She's on insulin. She takes Ozempic, semaglutide. So I'll ask Greg and Joe right now, do these drugs like semaglutide, Ozempic increase diabetic retinopathy severity? What do you think? Some studies say yes. Some say no. I've read studies that argue both. So that you can find a study that backs up your point. Some studies have said, though, if you're on semaglutide, especially Wegovy, which is Ozempic double strength, retinopathy often gets worse on these drugs. This patient's on metformin and doesn't have retinopathy at the moment. But I think we should just quickly touch on that. Have you seen patients on these glucagon-like peptide agonists, especially semaglutide, worsen in terms of their retinopathy severity? Either Joe or Greg?
I have seen them.
I have not.
I have seen them worsen, but I've seen them kind of go back to kind of a baseline, and if you want to say
Over time.
Yeah, and they kind of worsened, but then returned back to whatever. And so they didn't stay there, I guess is what I'm saying.
Yeah.
So not everyone.
And one can argue or postulate, is it the medication that's causing the severity, or are they on the medication because of the severity of their disease?
Totally, 100% agree with you. Yep. We see the same phenomenon in patients with bad blood sugar control that go on insulin. They get rebound diabetic retinopathy. Sometimes it's called glycemic reentry retinopathy. Your blood sugar enters a more normal range and the retina gets worse. So I've seen it go both ways. I've seen patients go on specifically Wegovy, which is semaglutide, and get way worse and not actually come back, go on and get proliferative retinopathy. But I've seen others that got worse for a little while, as Greg said, and then get better over time. So the current thinking by most kind of people in retinal biology is that it's how quickly the blood glucose drops and how much, because we see the same phenomena with any treatment that lowers blood sugar levels dramatically in a very short period of time. So those are people. Sorry, go ahead.
I think another comment would be, Paul, too, is, we fall into that conventional wisdom of not you, but, we as conventional docs, as opposed to functional, that this is a binary or linear type of, outcome. And we forgot about all the comorbidities and, all the other things that can affect this patient whenever they're getting this medication. So I think that's why we have all these subsets everywhere, because, we forget that everyone's an individual rather than one type, like you said, diabetic. So
No, it's true. I saw a calculator recently and it's free. So I should have saved the URL for it. I'll try to find it and send it out to the group if they're interested. But basically you put in the patient's current status, blood sugar, blood pressure, all that. Have they had an MI? Do they have normal kidney function and the like? What level of retinopathy do they have currently? And it basically says, okay, these are the meds that are the most cost effective for treating this patient for preventing cardiovascular disease or diabetic retinopathy. But it all hinges on how much money are you willing to spend, right? I would put every single patient on empagliflozin if I had my druthers, unless I've got urinary tract infections repetitively, because these drugs lower the risk of death and kidney failure and dementia. And by the way, recent studies showed they lower the risk of developing severe diabetic retinopathy by about 40%. These are the SGLT2 drugs like Jardiance, Farxiga. Another common one is Invokana. Okay, I'm sorry. I could talk about this one slide forever. So this patient.
Actually, Paul, before you get too far,
sure.
I want to pull you back a little bit.
Go.
A couple questions did come in. In the previous case, the 58-year-old, more peripheral involvement. What are your thoughts if the other eye has maybe 3 hemes total?
With more peripheral involvement, yeah. That's an interesting question. I think carotid artery disease. That's what comes to top of mind. When I say asymmetric diabetic retinopathy, I'm thinking of carotid artery disease. I have a couple of, I didn't include them tonight, but a couple of cases, I don't think I'm showing it, where the retinopathy typically is worse on the eye that has normal carotid flow and not as severe because blood flow is reduced in the eye that has carotid artery obstruction. I don't know if that's what the doctor's getting to in that question, but what do you do? I treat the eye that's bad.
Might have been it. Yeah, I think that might have been. I think that's kind of how I interpret the question as well.
Yeah.
A couple of the questions. New instrument called Aurora AI. Any experience with it? I don't. I myself do not.
I don't. No, I've heard about it. So I believe it's looking at metabolism within the photoreceptors itself. And so the whole notion here is that you're looking at functional decline in retinal, metabolism. And so I think it's interesting that I have no experience. A company that I consult to has wanted me to connect with the company that makes that device. So I'll report on it in the future if you'll have me back.
Where's the name of that medicine you put all diabetics on?
So the one I like is empagliflozin, which is Jardiance. It's a pill that makes you pee away excess glucose. So patients lose weight because they're peeing away calories. Their blood pressure goes down. The side effect that you would expect is urinary tract infections, right? Because you have more glucose in your bladder, more glucose in your ureters. So and especially in female patients, it's more prevalent. So patients are told, and I try to reinforce that when I see patients on these drugs, drink a lot of water, make sure you're peeing a lot so you don't get a UTI. But these drugs,
and they have good commercials too.
They do have good, yeah, they have.
Jardiance has good commercials.
Not a night goes by without a commercial with some jingle that, they must be selling the drug. Medicare covers Jardiance, empagliflozin, or Farxiga, which is dapagliflozin. I take the latter of those two off label for my type 1 diabetes because it's leveled out my blood sugar levels. I don't have the spikes that I used to have. It kind of levels things out. But the people that primarily are recommending these are cardiology. So I've gotten 300 referrals in the last couple of years from a specific cardiology office where I said, ask your cardiologist about empagliflozin because you already have congestive heart failure. And so he sent me his business cards and asked for a bunch of my business cards. So he's been referring people to me. So, there's lots of different ways you can grow your practice. Most eye docs probably don't talk to the cardiologist, but I do because I wanted to grow a diabetes practice. Now I got too many people. So I'll move on to the case, Joe, unless you have something else.
No, go right ahead.
I'll roll just so I can get through my cases. So this patient says, I'm doing everything the doctor told me to do, but my blood sugar, my A1C is bad. It's 8.5. I'm doing everything my primary care doc has asked me to do. And he told me I need to increase the amount of insulin that I'm taking. Now, I'll tell you about insulin. When you take more insulin, what happens? You gain weight. You're also more likely to get hypoglycemia. Patients can live for years with hyperglycemia, I functioned very well through college, probably with a blood sugar that was 300 half of the time. And I didn't pay the price until I got out of college and developed proliferative retinopathy. But patients cannot live. They can't function. They can't drive. They can't go to work. They can't have sex when their blood glucoses are low. So patients will do just about anything to avoid hypoglycemia. I think a rational decision is made by a lot of people to let their glucoses remain elevated. But I digress. This patient's worried about her A1C being too high. She doesn't want to take more insulin because she's already gained about 20 pounds on insulin therapy. She's also on Ozempic. She wears a Freestyle Libre CGM, continuous glucose monitor, which is the less expensive of the major ones on the market. I don't work for any of the companies. I wear their competitor's product. So I asked her, what's your mean blood sugar on the Libre? Because you can look at these continuous glucose meters and figure out what's your average blood sugar. Because they're measuring your glucose every 5 minutes out to 90 days. You could probably even go longer than that. And the patient said to me, huh? What are you talking about? Because patients don't know this, but now you know it and you can educate your patients. So here is her 90-day average blood sugar on her continuous glucose monitor. It's 142, and that's equivalent to an A1C of 7. But her measured hemoglobin A1C is 8.5. Why the discrepancy? I said, let's look at your labs. Let's go to the computer and look at your patient portal. Let's see what your labs say. And this was there for the PCP to look at. Her hemoglobin level is low. It's 8.4 grams per deciliter. Normal is 12 to 15. So what does she have? She has anemia. And so if you don't have enough red blood cells, the sugar in your bloodstream is going to stick to the blood cells that remain. So you're going to have a false high hemoglobin A1C. That's what's interesting about this case. And you can find that out. So I asked this question, is A1C still the cat's meow? I've already told you, showed my hand. I don't think it's a very accurate test because in about 1 in 5 patients, it's not accurate at all, particularly African Americans, people with any form of hemoglobinopathy, people that are taking ibuprofen or acetaminophen on a chronic basis. You get false readings on the hemoglobin A1C. For the last, whatever, it got invented, I think, in 1984, started being used in clinical practice in 1989. Hemoglobin A1C has been thought to be, the most important marker of diabetes control. And I don't think that's the case anymore. And here are the deficiencies I've already alluded to, that it's less accurate than oral glucose tolerance test for diagnosing diabetes. So why rely on it for that? It's actually not an average, it's a weighted average. So half of the value of any patient's hemoglobin A1C is determined by the blood sugar levels 3 to 5 weeks before the blood was drawn. So you actually can cheat the test. Don't tell patients this, but you can cheat it. And then patients with the identical A1C value may have very different mean average blood sugar levels determined by a professional, high-quality continuous glucose monitoring device. More deficiencies, iron deficiency renders values inaccurate, hemoglobin variance I alluded to, race and ethnicity, especially in African-American patients. And it also, A1C doesn't show you anything about blood glucose variability. And it's believed that when blood sugar levels go up and down, it creates more oxidative damage to the retina than does a continuous elevated level of blood sugar. So the highs and the lows, the ups and downs, have been shown to create more reactive oxygen species in the kidney, the retina, and the heart. So that may be another reason that A1C is not as predictive as we would like it to be for people getting worse. This is, I think, a really interesting study by Dr. Beck, the University of Texas. And he showed that people with the identical hemoglobin A1C, which is on the x-axis, have different average blood sugar levels on the y-axis. You can see there's a lot of variability. And he makes the point in his very interesting paper that a person with an A1C of 9% might actually have a better average blood sugar than a person with an A1C of 7%. That's what the data shows. So I don't trust A1C all that much. And most leading edge endocrinologists, they still do it because it's required to get their HEDIS scores, but they're turning away from A1C. So what's better? This is better. Glucose time in range, which is simply what percentage of the time is your blood sugar in a relatively normal range. And you can actually set the parameters on the low and the high end. What endocrinology uses is 70 milligrams per deciliter on the low end, 180 on the high end. So what you want to do is get your time in range high to be within that level. You also want to lower the amount of time you spend below range, less than 70, and the time above range. So these metrics are becoming very rapidly the gold standard in diabetes care. So I would encourage all of you to talk to your patients about whether or not they have a continuous glucose monitor. Ask them about their time in range. So I've highlighted, I think the more important study finding was that if your time in range gets worse, so it goes down, a 10% decrease in time in range increases your risk of developing and worsening diabetic retinopathy by 64%. And it also has a similar effect on microalbuminuria, which is early stage diabetic kidney disease. The most important thing here is it's totally independent of hemoglobin A1C. So after controlling for A1C, time in range was very predictive of who is going to get retinopathy and who's going to get worsening retinopathy. Here's my next polling question. So if you don't know anything about time and range, you're not going to know this, but maybe you've heard it from patients, maybe you've read about it. What's the recommended glucose time in range, TIR it's called, for most non-pregnant adults with diabetes? And interestingly, this morning in the journal Diabetes Care, they just published a study that said the same number applies to pregnant adults as well, because they showed benefits to the fetus in terms of its development, not being born with macrosomia, excess weight. So it's the same number for everybody that is an adult, as it turns out now, given this paper that came out this morning. 100%, above 70%, above 50, above 25.
Paul, as the respondents are coming in, question came in, anybody consider intermittent fasting? What are your thoughts there?
Yeah. I've got a dozen patients I've used it with. I got a case report about that in a moment, but I love it. I've had it's actually 13 people, all men. I haven't been able to convince a woman to do this, all 40 pounds or more above ideal body weight. The first patient was my friend from junior high school basketball. He lives 150 miles away from me now. He found my name on the internet and he came in, he said, my A1C keeps going up. They put me on insulin. I've gained a bunch of weight and now I've got erectile dysfunction. And he said, Paul, you're my last hope. I don't want to go on anymore because I can't have sex. And it sounds ridiculous unless you're a man, right? That's ridiculous. And I said, well, before you end your life, let's try something else. Let's try an intermittent fasting. Alternate daily fasting is what I did with him. And he lost about 60 pounds over 6 months, came back, cried, threw his arms around me and said, this is the best thing I've ever done. Why didn't somebody ever talk to me about this before? So the protocol I used is from Jason Fung, a nephrologist in Toronto, Ontario, Canada. So he says 1,600 calorie kind of Mediterranean type diet one day, the next day, just non-caloric beverages. So water, unsweetened tea, or coffee. And so I've had now 13, all men, most of them with erectile dysfunction, who lost 40 pounds or more, got their hemoglobin A1C lower, lost, inches off their waistline, lost a significant amount of weight.
And Paul, I'll just show you here real quick. There's
Yes.
my time in range. Purple is good and red is bad, and that's why I like doing it when I travel. I can see where I get myself in the troubles with the time in range. So
it's really useful, isn't it? Even if you don't have diabetes. So I have a father-in-law whose A1C is like 4.7, and he's worried, and he's 80 years old, and he's worried about his getting diabetes because his mom got it. It's like, Dad, your A1C is 4.7. His time in range, he got it because I helped him get it. It's 100% of the time. You're under 180, so don't stress yourself so much. But you've got a couple of bad colors there, right, Greg? So probably in your case, it's going to be useful to you.
Well, I have mine set for weight loss, which is 128. So that's why it gets into the the reds into the yellows or to the oranges, because I don't have it set at 180, but I have it set a little bit lower. All right.
If you set it to 400, you'll lose more weight because all the glucose is, you're peeing it away. You'll waste away. That's what happens to type 1 patients when they get diagnosed.
Yeah.
Okay, we have polling answers, which is, probably my guess would be most people say better than 50%. Am I right?
Well, you got 11% at 100. You got 70%. That's the winner at 63%. 50% is 22, and 25 is 4%. So the winner was 70%.
Yeah, so this is what the American Academy of Clinical Endocrinology says is you want your time in range to be above 70%. It's on the right side there. They have the individualized A1C on the left. So why might you want somebody not to have an A1C that's 5% with diabetes? Because studies show those patients are more likely to die. If they've got type 2 diabetes, you drive their A1C too low. Excess cardiovascular mortality in that group of patients, especially those that have poor cognitive function and pre-existing cardiovascular disease. So the bottom line here, I want the audience to know, is that the goals for everybody with diabetes are not the same. So if somebody's 80 with a lot of comorbidities, they've got cognitive issues, if you get their A1C to 8%, that's probably fine, right? Their life expectancy is not that long. And you can have a different approach for somebody who's 15 years old, with bad blood sugar control, no comorbidities yet, right? So the care of people with diabetes is supposed to be individualized. So this is my caveat in every letter I send to endocrinology or primary care physicianry is I've asked the patient to work with you on achieving their individually optimized metabolic targets, right? It's a way of saying I'm not stepping on your toes. You tell them what you want their blood glucose levels to be, but it would help me if you shared that with me so that we're giving complementary messages to the patient that we share. So I send letters every flipping day to endocrinologists and primary care docs and cardiologists. How often do I get letters back? Not very often. And so, it is a two-way street. It'd be nice to hear back from them more than we do. So there it is. Most non-pregnant adults, and as of this morning, now they're saying for even pregnant adults, 70% or above. So a consensus panel has recommended that A1C not be used as the universal standard now for studies involving diabetes care, to switch over to time in range, time above range, and time below range. And I'm right now a consultant on 3 different clinical trials. None of them are using these metrics because it costs more money and a lot of patients don't wear a CGM, right? So they're relying on the old has-been marker of diabetes control. It's not worthless. I won't go that far, but it's not as effective as is CGM data, continuous glucose monitoring data. So the gold standard in diabetes management, I think, is changing right in front of our eyes. Okay, so what went wrong in this patient? I'm going to look just so I can see where I'm at time-wise. I have till 10 till the hour. Is that right? I'm sorry, gentlemen. Just remind me.
Yep, you're
That
good.
is correct.
I got 25 minutes. Okay, so we're good. So what went wrong with this patient? It's another case outside of the eye, kind of, sort of. So 36 years old, type 1 diabetes. This person owns a heavy equipment company, sells heavy equipment, drives it all over the state of Washington. And he's got a little early retinopathy, and he's always had good glucose control. He's been my patient forever. But his A1C recently has gotten worse. So between 7.2 and 8.5, it had been in the 6s to high 6s for the last decade or so. And the most recent A1C that I actually did in my office with him was, I think it says 9%. It's blocked by my own face, 9.1%. So he's getting worse over time. So the question is, well, what happened? Why are things worse? So I asked him about his daily insulin dose. And he said, well, my blood sugar keeps going up. So my insulin dose has increased from 50 to almost 200 units of insulin a day. So this patient is hyperinsulinemic. So anybody taking more than 70 units of insulin a day exogenously via an injection, a pump, or even inhaled insulin, I got about 15 patients using inhaled insulin now. If you're using more than 70 units a day, you're hyperinsulinemic, and that increases your risk for cancer and also cardiovascular disease. The guy says I'm always high, even though I'm giving myself, almost 4 times as much insulin as I was taking before. And he's a smart dude. Went to the University of Washington, has an MBA, and he said, I swear I haven't changed anything. I'm doing what I've always done. His endocrinologist is president of the American Academy of Clinical Endocrinology in Seattle. I know him pretty well, and he's really cocky, and he doesn't like optometrists because 20 years ago, an optometrist didn't diagnose one of his patients with proliferative retinopathy. So, I've had a lot of conversations with him about, there's lots of people in optometry that do great jobs, some don't. Lots of people in ophthalmology do a great job, some don't, right? And so I've kind of convinced him. He's sending me more and more patients, especially after I one-upped him on this particular patient. So his endocrinologist is unhappy, says, you're lying to me, you're doing something that you're not telling me about. So what happened? So, all I said was, where do you inject, right? He injects insulin multiple times a day. And he said, well, I'm always driving. And I said, okay, you're driving, you're taking your shot in the car, you're clicking out an insulin pen. Where do you inject exactly? He said, well, it's typically on the left side of my stomach because I'm right-handed, and I'm jabbing through my shirt as I'm driving, heavy equipment to clients that have purchased the heavy equipment. So I said, okay, lift up your shirt. I don't usually say this to patients, but I do it more so now if their blood sugar control is erratic. And that's what his stomach looked like. So he has scar tissue, injection site lipohypertrophy. Okay, why does an eye doctor care about this? Well, because if we don't help this patient get better metabolic control, his retinopathy is going to get worse over time, right? So I sent a letter to the endocrinologist. His A1C told the patient to rotate his injection sites. His A1C dropped back down into the sixes. His insulin dose was cut dramatically back to 50 units a day. And I got this nice letter from the famous endocrinologist. His name is Earl Hirsch. He's written 12 books on diabetes. He and his brother both have type 1 diabetes. And super smart guy, has been voted the diabetes educator of the year like 5 times. But he said the patient's optometrist noticed this problem. And now, he told the patient to rotate his injection sites, and his blood glucoses have improved appreciably. So there you go. So I called him after this and I said, well, there you go. I found out a problem that you couldn't identify what was going on with this patient. I did. And he said, okay, I'll send you more patients, but kind of, angrily. So here's my financial planner. That's why the money sign is there. So I got to take care of this guy because he's managing my retirement assets. And I don't want to work till I drop dead asking patients which lens choice is better. So this guy comes in, been seeing him for the last 10 years. He's at a 3 diopter plus shift. He's 61, his BMI is 25. I checked his blood sugar in my office, as I often do. It's over 500. So that's not normal. We all know that. How do we know if this guy has type 1 or type 2 diabetes? And why is it important? I'll tell you why it's important. He went to his primary care doc who put him on metformin, called me a week later and said, my blood sugar won't drop below 400, no matter what I do. I'm taking the pill. If the only way I can not have my blood sugar be high is by not eating at all. This patient actually has type 1 diabetes. And there's a test we can all order or ask for that tells you whether it's type 1 or type 2 diabetes. It's called the C-peptide. So your body produces this protein when you're making your own insulin. If you don't have much C-peptide, you're not making much of your own insulin. Way more typical of type 1 rather than type 2 diabetes. Those patients with type 2 typically have a lot of insulin and high levels of C-peptide in their bloodstream. So his level was low. It's not high. He doesn't have type 2 diabetes. Mean C-peptide at the diagnosis of type 1 is 0.6, so he's a little better than that. In type 2 diabetes, the average patient has a C-peptide of a 5. And in LADA, which is this patient's diagnosis, the mean C-peptide is 1.1. Does anybody know the acronym LADA? If you look at your notes, you'll see it. It's latent autoimmune diabetes of adults. So my key here is that if you see a patient whose blood sugar is not coming down and they're being treated for type 2 diabetes, ask for the C-peptide test to be done. A lot of patients are diagnosed with type 1 diabetes when they are adults. So when I was a kid, I got diagnosed at age 5, and everybody said, oh, the mean diagnostic age for type 1 is about 15. That's not true. Now it's around 30. In fact, more than 40% of patients are diagnosed after the age of 30. I've got 5 patients in my practice now, all diagnosed age 70 or older with LADA. It's type 1 diabetes in adulthood. So the way you actually confirm this is by doing an antibody test or something called GADA. So you want to rule out other things like pancreatic tumors that could cause, death of insulin secreting cells. So he didn't have that. So he's got, the good news I told him is you're going to be okay. Your antibody testing was off the charts compared to what normal. You can see the range there at the top. And so he got put on insulin therapy and his A1C came down nicely. And this is my parole. 42% of type 1 is diagnosed after the age of 30. This is based on a multinational study looking at the epidemiology of type 1 diabetes. It's a lot more common than people think. Somewhere around 8% of type 2 patients diagnosed as type 2 actually have type 1 diabetes. So back to the eyes now. So I want to talk a little bit about AI using electrodiagnostics and patient education to help patients. hang in there with me. Keep, sending questions if you got them, and I'll try to get to them at the end. I'll stay as long as you want me to. So this guy's 33 years old. He got referred to me by my own endocrinologist, hadn't had an eye exam in 5 years. He sees 20/20. And he said, I don't know why the endocrinologist is making me come to see you. And later on, he told me actually he had seen another provider in Eastern Washington that told him he wanted to give him anti-VEGF therapy. But I didn't find this out till later on. So he actually had an exam earlier, but he lied to me and said it's been 5 years. I think he meant since he got new glasses. He only checks his blood sugar when he doesn't feel well, right? So you see that in patients. His A1C, again, this is back to metabolic memories, was bad for a number of years. He's taking a lot of insulin. Again, he's hyperinsulinemic. He got kind of spacey like I'm getting now in the exam chair. So I said, well, let's check your blood sugar. And it was 55. He's got hypoglycemia unawareness. So people with long-term diabetes, type 1 or type 2, lose the ability to know when their blood sugar is getting too low. So that's one reason to know how long somebody's had diabetes. If they've had it 30 years, expect them to get hypoglycemic in your exam room, be able to react to it, have a blood glucose meter. If your state board doesn't let you check blood sugar, your patient can check their own blood sugar, right? They can lance their own finger and you can put it on a test strip. Have something that's rapid acting carbohydrate in your office, like an OJ, an apple juice, a Coca-Cola beverage, something like that. Here's what his retina looks like. You can see, it's got a fair amount of retinopathy with some vein beating there, got some cotton wool spot formation. These are not great photos. I do all my own photography. That's why the photos are mediocre at best. Here's the left eye, very similar kind of picture, more cotton wool spot formation. So I had been loaned by the University of Southern California an algorithm, an AI program that they had developed there called iNook. I don't work for them. They just wanted me to try it out in my office. So I ran this guy's images through artificial intelligence, and it came back with severe non-proliferative diabetic retinopathy. And the patient, I said, we should have you see a retina specialist, consider you for anti-VEGF therapy, or at least introduce you to the retina doctor, because the way things are now, you're at high risk for progressing and needing treatment in the near future. But the patient, like a lot of young men who are not, thinking about the future, say, I don't want to go. I don't have any symptoms. Leave me alone. So I showed him pictures of people that lost their vision. I try not to be a jerk and cruel to patients. Sometimes you pulled out all the stops and patients still don't want to listen. Jay Haney said something to me in Nashville at AOA a couple of days ago, which was, I tell patients, well, I'm the doctor. Why did you spend money? Why did you waste your time coming to see me if you're not going to listen to what I recommend to you? And that's probably the right response. But I reviewed, all the things that show him he probably should be considered for anti-VEGF therapy. He's got severe NPDR, and we know these patients are less likely to lose eyesight if they get treated with anti-VEGF therapy. That's been shown in several trials now. So there's just the enlarged diagnosis from the AI. So this is the picture I showed him. This is somebody that had a 2-step improvement using injections into the eye. And, he didn't want injections, of course, because he sees well and he doesn't have diabetic macular edema. But, I was trying to kind of twist his arm a little bit. So this is my next question, and I'll roll into the next topic here. Per a 2023 abstract presented in Kyoto, Japan, which test was the best predictor of somebody going from non-proliferative diabetic retinopathy to PDR, or center-involved diabetic macular edema, over the next 48 weeks? Color fundus photography, and this was interpreted by an image reading center. OCTA foveal avascular zone area, full field electroretinography with pupillometry, or an ultra-wide field fluorescein angiography ischemia measurement, multiple measurements actually. So I'm trying to talk about technology right now, so you probably have figured out, it's probably not the color fundus photography. So I'll just give that, I'll give that one away, just say it's not that. It's one of the other 3 things.
Well, I can see the polls rolling in, and
good.
Before you said that, no one did respond color fundus photography. So
awesome.
Joe, we caught up in the chat box. I don't want to take a look. I think it closes.
We're good.
The poll.
No, we're good.
Perfect.
So
all right,
prior to this study, I would have thought the answer was probably going to be the last answer, right? Because FA has always been the gold standard for everything, right?
Well, that's where the audience is leaning. We've got 0 for color fundus photography. We got OCTA and the avascular zone for 36%. Then we got 18% full field electro retinography combined.
The O is out. I'm sorry. I misspelled electro. What the hell's wrong with me? I got to proofread my copy before I go on.
That's okay. I caught them and put them in I got the visual one earlier too, but that's okay. I just didn't have your slides. And then 44%. So basically D was the ultra wide, the fluorescein, ischemic indicating the ischemic indices. So that was 46%, followed by OCTA, followed by the pupillometry and ERG.
And I would have said D too, until I saw this data, which said that's not true. So electroretinography was actually the most predictive. And I'll show you the data in a moment. So what's an ERG? It's basically an EKG of the eye, of the retina, right? So you got a normal person there. That's the dark color. And what we look at in an ERG is how long does it take for the signal to get generated? That little negative sine wave, the curve that goes down, that's actually the A wave. That always confuses me because I think of A being above the line, but it's below the line. So that person has a nice electrical signal from the retina. The person with diabetic retinopathy that's in the fainter, the fainter colored line doesn't have as robust a response. And it also took that person longer to respond. The amount of time in milliseconds it takes for the response to get generated is called the implicit time. So it's just showing you a control eye versus somebody that has diabetes and some diabetic retinopathy. And this is using a full field flicker ERG. I hadn't done one of these tests, since I was in third year of optometry school because it was a laborious process, right, with big apparatus. The data shows this, that as diabetic retinopathy gets worse, the ERG gets worse. You can see the amplitude of the ERG is getting lower. It's taking longer for the signal to get generated as the diabetic retinopathy severity gets worse. That's all this slide shows. So this was the first study that I started looking at this technology after reading the study. It was done in the US, 237 people. The primary outcome was those that needed treatment within the next 3 years. Laser, anti-VEGF therapy, intravitreal steroid placement. And so what they showed was that in patients that had severe, let me think of how to say this, severe non-proliferative diabetic retinopathy and an abnormal ERG, that was the most predictive of who was going to need treatment in the next 3 years. And if you look at the middle two there, having an abnormal ERG score, the higher the number, the more abnormal you are. So having an abnormal ERG, but no signs of severe non-proliferative retinopathy, that actually was about as predictive, a little better than was a normal ERG and having signs of severe non-proliferative retinopathy. Everybody hangs their hat on, does the patient have severe NPDR? Well, as it turns out, it's not all that, it's predictive, but not as predictive as we might want it to be. So combining structural findings, vein beating, microaneurysms, hemorrhages in all 4 quadrants, IRMA, if you combine that with the electroretinography, it's more predictive than any of these things by themselves. And that's what's highlighted there. So this is the device, and it's handheld. You can move it from room to room. There's a couple of companies that have these out there now, and it measures your implicit time and your amplitude, and it gives you a score. Again, the higher the score, the more abnormal your retinal function is. Simultaneously, it's measuring your pupil's response to different stimulus intensities on the flash, not the flash, on the full flicker ERG. You can kind of sort of in the picture see there, it's an electrode that's placed on the lower eyelid under the pupil. This is not actually very good placement. This is not my patient, but it's supposed to be closer to the eyelid margin. This person has a score that's above 23.5. So the computer algorithm says this is outside of normal limits. So here's an actual patient of mine, the patient I just talked about, the guy that didn't want to go to the retina specialist. So I did an ERG on him, and you can just look at the amplitude, and it's abnormal in both eyes. His implicit time is largely abnormal as well. His score is 26.9. So he's way outside the threshold for probably needing treatment if the study I just presented you is to be believed, right? So this was presented, and this is the study I alluded to in the poll question in Kyoto, Japan, the International Clinical Electrophysiology and Vision Conference. And so what they looked at were these 4 markers for who's going to get PDR, or center-involved diabetic macular edema. The least accurate, the least predictive, was color fundus photography, as the smart audience noted. The most predictive was the DR score using ERG plus pupillometry. Now, ultra-widefield FA was useful. Depending on what protocol you used, it was more or less predictive. OCTA was useful, but both of these were outperformed in this particular study by an abnormal ERG plus pupillometry. So that's interesting. You need bigger studies with many more patients, many different levels of severity, but I think it's interesting. Again, just to show you, you can't rely on clinical exam or color fundus photography in particular. So I told him you have a high risk of severe irreversible vision loss within the next year based on the appearance of your retina and the function of your retina. I probably didn't use those words. It was, look, you're at high risk. I don't want you to lose your eyesight because I almost lost my eyesight in my 20s. Don't be stupid like I was and not go to the retina specialist until your big brother, who happened to be an optometrist in my case, dragged my sorry rear end to see the retina specialist when he was an optometry student. And you know what the retina doc said to my brother and me? He said, it's a good thing your brother dragged you in here. You probably were going to be no light perception within the next year without treatment. I had florid optic nerve neovascularization. So I told the patient, if we treat you early, we may help be able to prevent this. Let's just see a retina specialist. You don't have to do anything, but why don't you just go talk to the retina specialist? Because in general, I like people to meet the retina doctor, you know, on a visit where they're not necessarily getting a needle put in their eye. So it's a less, you know, anxiety provoking situation. And then I always say to my patients, you know, come back and see me after the appointment that I'm going to make for you. And he actually agreed to go because he said, okay, you keep bothering me. I'll go see the retina doctor. And I make the follow-up appointment so that the patient, hopefully if they fall through the cracks, I have another opportunity to get them back in with the retina doctor. So I told him, we're trying to keep you here and not progress onto this slide I borrowed from a retina doc in Houston. And this is my phraseology now that I kind of stole from a couple of friends of mine, Steve Ferrucci and Jeff Gerson, that use it, which is, you're at the edge of a cliff. I'm trying to keep you from taking another step and falling off the edge of the cliff. So as I said, this guy was convinced to go in, and I actually did his ERG again after he had had a few anti-VEGF injections, and it got better. His ERG score was 26.9. Now it's 24.7. It's not normal, but it's better. It's not getting worse. His retina looks a lot better. I don't have the photos, unfortunately. I should have shown them to you. So how do we prevent diabetes and diabetic retinopathy? I'm going to look really quickly. I don't have time. So what causes diabetes? A lot of stuff. It's not just obesity. There's a lot of things in the environment that patients have zero control over, including their genetics, air pollution, how much their mom breastfed them that contribute to diabetes. Here's a patient with a lot of risk factors for diabetes. He's got pre-diabetes, and he takes a bunch of meds you can read on the list there. I'll cut to the chase. He's obese. He's got abdominal obesity. He's got low macular pigment, not a lot of carotenoids in his macula, doesn't eat many fruits and vegetables. His mom had diabetes. So he's got a whole bunch of risk factors. So why do we care about preventing diabetes? Because about 50 to 60 people in the US go blind every day from diabetes. And you're not going to go blind if you don't get it. So these are all his risk factors. The one I talked about earlier was high-dose thiazide diuretic, 50 milligrams. That's a risk. These are all independent risk factors for developing type 2 diabetes based on the literature. Prevention beats cure. So this is what I did. I gave the patient my recommendations. I copied his physician on the note and on the tips I gave him, which if you want, I can send to you. It's probably my most prized slide is the next slide that I'll show you. I asked patients to write down what I told them and pick one thing that they are committing to improve upon before I see them the next time. It's motivational interviewing to get patients to buy into your treatment plans, the idea. And remission does occur after bariatric surgery. So that intelligent question was asked earlier. So this guy I talked to about alternate daily fasting, the Jason Fung protocol, he is now walking 10,000 steps a day. He lost 55 pounds. His A1C is down to 5%. He's not taking hydrochlorothiazide anymore because I told his PCP to take him off it. He put him on an ARB drug. He stopped smoking. His macular pigment got better on a diabetes-specific supplement. And he said, this is the best thing I've ever done. Why didn't somebody tell me about this before? This is my 5-6 years of my life working on this, which was using an AREDS2 type formula to prevent diabetic retinopathy from worsening and to improve visual function. So a lot of the stuff in AREDS2 is actually in this formula, but a few things that weren't in the formula. If you want to read about the study, it's the Diabetes Visual Function Supplement Study, got published in the British Journal of Ophthalmology. Stu Richer, kind of a mentor to me, and a couple of other friends did this with me. The bottom line on the study was we showed clinically meaningful improvements in visual function in everything. The thing that blew me away was that C-reactive protein levels significantly went down in patients on this particular formula. So I'm recommending it to patients because I don't want their eyes to get worse, but there may be some benefits from a cardiovascular standpoint. CRP destabilizes vulnerable atherosclerotic plaques. That's what leads to MI and stroke. So okay, this is my last case, so I can do it. I got 1 minute. You'll let me do it, I hope, gentlemen. So 69 years old, type 2 diabetes for 7 years. Patient just got diagnosed with Alzheimer's. She's stressed out of her mind. I did the ERG test on her. She had a high score, not out of the normal range, but still high. And I put her on this formula, and she came back 6 months later, and her score went down dramatically. It's about a 60% reduction in the risk for needing a retinal intervention over the next 3 years. So that's kind of cool. So, people say to me this, why didn't my other doctors tell me this? Well, because they don't have time or they didn't know. This is the most important quote, I think, from Elliot Joslin, who founded the Joslin Diabetes Center at Harvard. Diabetes education is not part of the treatment. It is the treatment. We need to educate patients. Optometrists can play a really important role. Joe and I have a friend and colleague, and I'm sure Greg knows him too, Joe Pizzamenti, that did an interesting study published in a diabetes journal showing that patients knew more about their diabetes when they saw an optometrist, a psychologist, and an endocrinologist than they did by seeing any one of these providers on their own. So we can work collaboratively with other people. My predictions are basically we're going to be seeing more and more diabetes. I think ultimately optometrists are going to be authorized to treat diabetes with some oral agents. We will be probably treating diabetic retinopathy with topical and oral therapies. Light-based therapies, photobiomodulation, I predict in the future will become prevalent. We'll see if I'm right. We're healthcare providers like everybody else. We're all on the same team. The key message for patients is to remind them seeing well doesn't mean you have healthy eyes. We all know that. And then for us, we play a really important role in diabetes care. And we are going to be needed more and more as ophthalmologists retire and the population swells of people that have diabetes. Thanks for indulging me, guys, for the extra, actually, maybe 30 seconds. I got 6:50 on my clock. Am I good?
You nailed it. I'm going to there's a question that rolled in. Before we do the question, I'm going to stop you from sharing. I'm going to share my slide here real quick. I just want the audience to know right here, if you go and want to start the survey, so you don't have to do it at 10 o'clock, you can start the survey right here. And I'm going to move into the question, and you're getting your virtual round of applause right now. But someone asked, have you heard the term type 3 diabetes for Alzheimer's?
Yeah. And this is pure coincidence, but my freshman biology teacher at Brown University, Providence, Rhode Island, is the first person to publish a paper showing that the brain itself makes insulin. And so she had done work that showed brain insulin deficiency was one of the hallmarks of Alzheimer's disease. So a lot of people are calling it type 3 diabetes. That's exactly correct. Diabetes seems to double the risk of any dementia. Alzheimer's disease specifically, it's about an 80% increased risk. Great question.
Yep, that is a great question. Yep, that is a term. There's type 1, type 2, type 3, 1.5. There's different ones that are out there. So
yeah, 1.5 is just kind of a combination of insulin deficiency and insulin resistance, right?
Yep. There you go. You're getting them to roll in here. It says, excellent lecture, very interesting tonight. You're a great lecturer. So they're rolling in here. So with that being said, Dr. Chous, OEC would like to thank you for doing diabetes cases. This was a synchronous virtual course. Thanks for doing the polling, everyone. Thanks for putting the questions in there. Joe, any final comments before, or I'll make the comments, hypoglycemia, that was great tonight. Hemoglobin A1C, time in range. I think it delivered us a lot of a lot of new information for the audience. Joe, any final comments before we end the education?
I thought it was, I agree with the audience. I thought it was excellent, Paul. I mean, I don't feel like I was lectured to. I felt like I was conversed to. And it's really a privilege to hear somebody who is so versed in a topic that is so second nature. So we do thank you, Paul. It was terrific.
It's an honor. And Greg, thanks for cherry picking the responses to my talk. I'm grateful to both of you for inviting me to present. It's really great. Anybody has questions? My email's not on here, but you're more than welcome to shoot me an email if you want to talk at more length than I was able to tonight. Thanks again, gentlemen.
Thank you.